Assalamu alaikum now. Okay, first of all, this is CMS neurology, very important topic for the upcoming years. Emily. I have done the blocks and now I would like to discuss something and what are the mistakes have I done or what are the clues you need for this. Okay, first question, 7-year-old, progressive sleepiness, ataxia, double vision, this and that, received erythromycin for pharyngitis. Her brother has ADHD. She appears sleepy. These 7-year-old girl came with the complaints of progressive sleepiness. So this one is important. Progressive sleepiness, ataxia, double vision for past 2 days. Why these happen? These happen due to the anti-epileptics carbamazepine. This 7-year-old girl is taking carbamazepine for why? Or complex partial seizure. Carbamazepine is a common anti-epileptic medication. It has been shown to interact with other medications, and Caution should be exercised when choosing concomitant medication for treating these patients. It's a CYP inducer, which may increase the hepatic clearance of some medication, like most chronic alcoholics still fen and never refuse greasy curves like modafinil, phenytoin, valproic acid, warfarin, these sort of drugs leading to subtherapeutic concentration of the serum. Other other drugs such as erythromycin can interfere with the hepatic metabolism of the carbamazepine by inhibiting the CYP450 enzymes, leading to decreased carbamazepine clearance, increased serum concentration. Erythromycin decreased uh, carbamazepine clearance, increased serum concentration and toxicity. Carbamazepine toxicity typically presents with altered mental status. Carbamazepine toxicity typically presents with altered mental status, drowsiness, ataxia, nystagmus, nausea, vomiting. Diagnosis can be made by measuring a serum carbamazepine concentration above the subtherapeutic level. Um, there is a dose-dependent effect on neurologic depression. Dose-dependent effect of the neurologic depression. Treatment is separated with benzodiazepine for seizures or agitation, and involves discontinuation of the offending drug. Why it is not? Looks like he has some sort of, but he has fever. I don't know why I choose viral encephalitis. Viral encephalitis comes with fever, altered mental status, neurological abnormalities such as seizure, aphasia, hemiparesis, or cranial nerve deficit. This patient does not demonstrate fever and a carbamazepine erythromycin interaction. Okay, next question. This is also wrong. This is lumbar spinal stenosis. Why? I thought it may be PVD. Why it is lumbar spinal stenosis? This 52-year-old, these patient symptoms are most concentrated in neurological claudication. Uh, he has some sort of neurological claudication. He has noticed the pain is less intense, but if he leans or something as he walks, such as grocery carts, he noticed that pain is less intense if he leans. This word is very high end. When he leans forward, when he's taking the grocery cart, uh, his pain is less intense. It is also called shopping cart sign. He has noticed that the pain is less intense if he leans or something as he walks, such as grocery cart. He can still ride and exercise on bicycle without developing any pain. So he can ride bicycle. In bicycle, you have to forward flexion and forward flexion. If forward flexion, pain disappears. Looks like lumbar spinal stenosis. Okay, lots of clue is present, but what happens? Our mind does not find those clues because it is very intense to read the whole question. to make yourself calm down. The patient's symptoms are most consistent with neurologic claudication caused by lumbar spinal stenosis. Spinal stenosis is described as the narrowing of the central canal neural foramen, narrowing of the central canal neural foramen, or lateral recess of the spine with um, mm, consistent nerve compression. Common causes include degenerative arthritis, spondyloarthritis, degenerative arthritis, spondyloarthritis, and degenerative disc disease, hypertrophy of the ligamentum flavum, hypertrophy of the ligamentum flavum, and osteophyte formation in the facet joints. Neurologic claudication describes lower back pain with radiation to the buttock. There is a lower back pain, radiation to the buttock and lower extremities that results from increased nerve contraction, increased nerve compression, as may occur with extension of the extension of the spine during standing or walking down. Lengthening of the spinal column with spinal flexion as during sitting, walking uphill, and leaning against the grocery cart tends to relieve the pain. Diagnostic evaluation involves X-ray followed by MRI of the lumbar spine, X-ray followed by MRI of the lumbar spine. This is very common question, Bell's palsy. So in Bell's palsy, prednisolone therapy is the most important. This is very confusing question, epidural spinal cord compression. So this patient's presentation, signs and symptoms of focal back pain, upper motor neuron sign, focal back pain, upper motor neuron sign, and weight loss are suggestive of weight loss and weight loss are suggestive of epidural spinal cord compression caused by metastatic carcinoma. Metastatic disease frequently Metastatic disease frequently affects the vertebral column. Metastatic disease frequently affects the vertebral column and may cause compression of the spinal cord. Um, by extending into the epidural space, or by causing bony destruction or fracture of the vertebral bodies Patients present with back pain, lower extremity weakness, patient presents with back pain, lower extremity weakness, loss of balance, urinary or bowel incontinence, or complete paralysis, urinary or bowel incontinence, complete paralysis of the lower extremity. Early detection and treatment are crucial to prevent permanent spinal cord damage and myelopathy. Patients may benefit from short-term treatment with IV dexamethasone to decrease the spinal cord edema, IV dexamethasone to decrease the spinal cord edema, although definitive treatment requires a combination of surgical decompression, chemotherapy, and radiotherapy. Surgical decompression, chemotherapy, and radiotherapy. Okay, this is lumbar spinal stenosis. Lumbar flexion is full and extension is limited. This word is very classical for lumbar spinal stenosis. So the patient symptoms are best explained by lumbar spinal stenosis. Spinal stenosis describes narrowing of the central canal neural foramen or lateral recess of the spine with consequent nerve compression. Common causes include degenerative arthritis, spondyloarthritis, degenerative disease, hypertrophy of the ligamentum flavum, osteophyte formation, hypertrophy of the ligamentum flavum, degenerative disease, spondyloarthritis, lower back pain with radiation to the buttock and lower extremities that results from increased Nerve compression is called neurologic claudication. This is exacerbated by extension of the spine during standing or down or walking downhill, lengthening of the spinal column, lengthening of the spinal column with spinal flexion as during sitting, walking uphill or bending forwards, and bending forward tends to relieve the pain. The absence of ankle reflexes suggests the involvement of the S1 nerve root. This is post positional BPPV. This is BPPV. This called by for the diagnosis, aptly for the treatment. Malposition, the otolith move within the semicircular canal, move within the semicircular canal and stimulating abnormal movements of the endolimb. A 35-year-old woman. mm, uh, a 35-year-old woman has constant burning pain in his right hand since closing her hand in a car door 1 year ago. Examination immediately following the injury showed extensive ecchymosis and swelling. No fractures were identified, but the hand was placed in a cast for 1 month. She is unable to tolerate light touch or any motion of the wrist, during current examination, which of the following? So abnormal sympathetic response, also known as reflex sympathetic dystrophy, or uh, abnormal sympathetic. This one is a very superstar question. This one is a very so this concept is a very high level concept. uh, so abnormal sympathetic neural response, also known as reflex sympathetic dystrophy, a complex regional pain syndrome, or a complex regional pain syndrome can potentially occur after traumatic injury, and has a variety of clinical characteristics. Commonly, hmm, commonly patients may develop uh, commonly patients may develop pain out of proportion to a degree pain out of proportion to the degree of the injury in a distinct anatomic location that does not correspond to a single nerve or dermatome. The exact pathology is unknown. Mm, so this 35-year-old woman has a constant burning pain in the right hand while closing her hand in a car door. Since closing her hand in a car door, examination immediately show following injury: extensive ecchymosis and swelling. No fracture were defined, but has no fracture were defined, the hand was placed in a cast in for a month, and she's unable to tolerate light touch or any light touch or any. Okay, abnormal sympathetic neural response, reflex sympathetic dystrophy, complex regional pain syndrome. All three are same, can potentially occur after traumatic injury, and has a variety of the clinical characteristics. Okay, this is AIP. There is UTI, sulfonamide. AIP most likely diagnosis abdominal pain, peripheral neuropathy, gloves and stockings pattern, neuropathy, gloves and stockings pattern, which is caused by autosomal dominant mutation in the porphyrin deaminase gene. This enzyme catalyzes the third step of the heme synthesis. This enzyme catalyzes third step of heme synthesis, which combines four porphobilinogen molecules into porphobilinogen, which is subsequently converted to uroporphyrin. Loss of enzyme leads to accumulation of porphobilinogen, which is toxic to the nervous system, increases toxicity. Okay, it's PMR, polymyalgia rheumatica, Okay, this is very tough to diagnose. The temporal joint forms the articulation between the mandibular condyle and the glenoid fossa. The temporomandibular joint. Okay, 11. This one is very tough. I actually a bit confused. Is it Huntington's or not? 42 year. Mm, but he has, but she has involuntary movements of the upper extremity. She has involuntary movements of the upper extremity. He goes cramping several times. These are gates and attention. So atrophy of the caudate nucleus and brain imaging. Caudate loses acetylcholine and GABA. This is Huntington's. These word goes for Huntington. Hunting. So this one is goes for Huntington. Atrophy of the caudate nucleus and brain imaging would be expected in patient who most likely Huntington disease, a progressive neurodegenerative condition, that arises from misfolded protein as a result of trinucleotide expansion in the Huntington gene. As a result of trinucleotide expansion on the Huntington genes, patients develop choreiform movements which are characterized by involuntary flaying motions of the upper extremity. Eventually, these motor disturbance and others include ataxic gait, therefore anticipation. Okay, this one is very important. Actually, I don't get it. Acute focal neurological deficit, motor weakness, confusion, dysphagia. Dysphagia is concerning for thromboembolic cerebral infarction, or stroke. Thromboembolic cerebral infarction or stroke. It is acute focal neurologic deficit. The acute onset focal neurologic. The acute onset focal neurological deficit motor weakness confusion dysphagia is concerning for thromboembolic cerebral infarction or stroke. Atrial fibrillation is a major independent risk factor for stroke, and stroke prevention is an essential aspect. Stroke prevention is an essential aspect of the management. The loss of coordinated atrial contraction in the dysarrhythmia results in blood stasis within the atrial compartment, and the promotion of the thrombus formation embolism to the cerebral arteries results in ischemic stroke. The presence of right-sided hemiplegia, expressive dysphagia, and are suggestive of lesion involving the left MCA artery distribution. The middle cerebral arteries are the most common cerebral arteries involved in acute thromboembolic stroke. Acute onset focal neurological deficit, motor weakness, confusion, dysphagia, and concerning for thromboembolic cerebral infarction or stroke. Atrial fibrillation is a major independent risk factor for stroke. Stroke prevention is essential. Ah, okay. So dysarrhythmia. So atrial fibrillation is the most independent. So ECG atrial fibrillation is the most independent risk factor for ischemic stroke. Atrial fibrillation most independent risk factor for ischemic stroke. Mm, Preventive anticoagulation should be considered in patients with additional risk factors like congestive heart failure, hypertension, advanced age, TM, prior stroke, TIA, atherosclerotic cardiovascular disease, atherosclerotic cardiovascular. Now number 13 looks like NPH. Okay, I actually uh, has dementia. The patient has normal patient hydrocephalus, dementia, gait sensibility, urinary incontinence. So the gait is wide based, tandem walking, wide based, tandem walking. Mm, okay, this one he has few episodes of urinary incontinence. Though I diagnosed right, but I actually lag behind finding out clue. I thought I have found some questions that even if there is no urinary incontinence, the NPH can happen. NPH is a very high yield concept in the upcoming USMLE exam. I know that. Very high health. Okay. Okay. So we have done 13 question. We will do it rest. So it's a part one neuro 6 part 1 neuro 6 CMS form. Hope you enjoyed.